be your instructor for today. Can you please introduce yourself? Tell me your names, please.
دكتور أشرف صلاح.
دكتور عمرو الحسني.
دكتور مروة غلاب.
دكتور
تسليم. دكتورة إيمان. Nice to meet you all. So we will start our case presentation. I will be reading stems. Britain Edward is a 27-year-old accountant who attended her duty with fever, arthralgia, and rash. Some blood tests were performed, which show a creatinine of 194 micromole per liter. I can tell you that this creatinine is raised. She is referred urgently to the renal service. What aspects of the history are important to clarify?
When did her illness start?
Okay, what else?
Any preceding infection or symptoms like a common cold or sore throat.
Anybody has any thoughts?
I want to know more details about the fever.
Okay.
Any respiratory symptoms like cough? I want to know about gastro symptoms, review. Did she have any diarrhea? What medications is she on? Like this?
Okay, that's good. Let's proceed for the sake of time. Okay. So I'll be reading this slide. So some of the information that we need to know, as you mentioned, guys, when did she become unwell? Any illness in this episode? And we need to know about systemic symptoms, like there's a fever, rash, arthralgia, and if she had any sweat and respiratory symptoms, either lower or upper respiratory symptoms, if she had any eye symptoms, like this. As you mentioned as well, any medications that can cause her renal impairment, and any previous or similar episodes or possible history of autoimmune disease, any previous reports of renal function, which is really very important, and any possible history of any other associated illnesses, or if she had any cause of her acute rise of creatinine, like fluid losses, diarrhea, or vomiting. Okay? Are you okay?
Okay.
So I will be doing as well to present some illness to answer your questions. So she was being unwell for 2 months. She had symptoms of dyspepsia, which started after she took some ibuprofen for a weekend, sustained while she was skiing. Initially, she had self-medicated with Gaviscon and Varenicline over the counter, but then her indigestion persisted and became worse for around 1 month. And then she started to attend her GP, who would prescribe the new medication 1 week. Later, she noticed a faint rash on her arms. Okay? So here, the review system showed daily fevers, arthralgia of the small joint in the hand, intermittent joint pain, but there was no history of upper or lower respiratory tract symptoms. Her cardiovascular system was unremarkable. There were no GI symptoms at all, and no neurological symptoms.
Okay.
So proceeding with the past medical history and family history, she did not have any past medical history notes, and the family history as well was not revealing any renal or autoimmune diseases. Medication history, as all of us I wanted to know, she had only oral contraceptive. She was taking this for the last 7 years, and as we mentioned, she took ibuprofen for her yeast pain, Gaviscon and Varenicline for dyspepsia, and a new medication that she doesn't know the name. Okay, let's proceed. Ms. Edwards' GP was contacted and confirmed that she was started on omeprazole. And we asked him if she had any previous documentation of renal function. Some bloods were performed 5 years ago as part of a routine employment. These show the creatinine of 68 micromole per liter, keeping in mind that the normal range is 62 and 106 micromole per liter, suggesting that the current decline in renal function is likely to be active. Okay, so the question for the slide, what do you want to know now?
Vital signs like blood pressure, pulse, respiratory rate, and temperature.
Okay, that's good. Any other thoughts?
I'm interested more in the rash.
Okay, who else?
Maybe to know more about abdomen examination.
Okay, that's good. So let's proceed for the next slide. So vital signs, Dr. Ashraf, showed that she's having a temperature of 37.4 degrees Celsius. Her blood pressure was 145 over 90 millimeter mercury, and respiratory rate was 16 breath per minute. Okay, and this is the rash that she had. Can anybody describe this rash, please?
It's red involving the whole arm. I can say it could be a maculopapular rash.
Excellent, Dr. Marwa. Thank you. What do you think these patients have from the past history that we gave in the examination? Any thoughts?
Well, it's difficult since we don't have all the information, but I think this could be an acute tubular necrosis. I have seen one patient in the round.
Okay, that's excellent, Dr. Amro. Can you summarize how does ATM present? Because you know that we can have an abbreviation. ATM stands for acute tubular necrosis. Can you tell me how does it present?
Maybe like fever, rash, abdominal pain, some medication involved, renal impairment.
Okay, that's excellent. Thank you very much, Dr. Amro, for your active participation. I would like to hear more from Dr. Iman and Dr. Hiba in the next slide, please. Okay? Okay. So, as we mentioned, there is an erythematous maculopapular rash, predominantly over the dorsal forearms, and she had it as well. Okay? Abdominal examination, as we wanted to know, revealed mild tenderness in the flanks bilaterally. Okay, and other systems examination was underway. Okay? Okay, so what is the most likely underlying cause for renal impairment? I think we answered this question. As Dr. Said, we think that it could be acute tubular necrosis. And the typical clinical presentation of acute tubular necrosis includes, or tubular interstitial necrosis includes symptoms of fever, rash, abdominal and pain, resistance or infection as well, hypertension, and acute renal failure. So as you see, her creatinine was a little bit elevated, and she had a little bit high blood pressure. Okay, so what do you think that we should do next?
Investigation.
Okay, can you be specific, Dr. Iman?
Okay, I want to know the electrolyte. Maybe repeat creatinine reading to see the trend, is it going up or improving?
Okay, that's a good answer. What else?
Maybe white blood cell count.
Okay, are you interested in specific cells?
Xanathans?
Excellent answer, Dr. Marwa. Thank you very much. Okay, so let's see the labs. Okay, so we have the labs as you can see here. Her sodium is 139, normal. Potassium is normal. Urea is elevated, 14.3. Creatinine is even worse, 201. ASR is high. She had slightly low albumin. Her hemoglobin is below the normal range, and she had quite well eosinophilia, as you can see, like eosinophils are 1.2, and the normal upper limit is it was slightly elevated, and her CRP was higher. Okay, so she had quite abnormal labs, as you can see. What else would you like to expect?
Maybe radiographic examination.
Urine analysis maybe also. I think urine analysis, yes.
Okay, what do you expect to see in the urine analysis? Okay, what do you expect to see in the urine analysis? Dr. Hiba, can you please answer?
Abnormal protein or presence of albumin in the urine, which is coinciding with the renal failure.
Okay, excellent, Dr. Hiba. Please keep it up this way. It seems that you have actually good knowledge. Okay.
Okay, thank you.
Okay, that's good. Okay, what else, guys?
The autoimmune workshop.
C. So he had the urine dipstick, which was positive. Okay, so the urine dipstick showed protein, blood, and leukocytes, and a sample was sent for microscopy, culture, and sensitivity. Okay, I can tell you that normal urine analysis is negative for protein, blood, and leukocytes. What other labs are you interested in know, guys?
I think autoimmune workshop.
Okay, autoimmune workup. Dr. Ashraf, what and why? What are you requesting and why you are requesting this?
Well, I think we should exclude lupus nephritis by doing anti-nuclear antibodies, anti-Smith and anti-double-strand DNA antibodies to exclude lupus nephritis.
Okay. Okay, that's interesting thought, Dr. Ashraf. Okay. How are you going to proceed with these investigations? We are not done yet. Anything else, guys? Come on, guys. Anything else that you would like to request?
Maybe renal ultrasound?
Yes, Dr. Say it loud, please. Okay. So, what do you want to do? Why do you want to do the ultrasound, Dr.
Basically, I would like to exclude obstruction as a cause of her renal function, impaired renal function.
That's good, actually. Okay, so to answer Dr. Ashraf's questions, she had normal coagulation profile, complement C3 and C4. She had negative ANA, anti-double-stranded DNA, IgGs, ANCA, anti-GBM antibodies, rheumatoid factor, and cryoglobulin. So we ordered even more blood tests trying to explain her renal impairments, and all of them came negative. Okay. And to answer Dr. Amr's questions, she had an ultrasound of the urinary tract, and the ultrasound showed that her kidneys were normal side and obstructed. Okay. Okay. So I will ask this question. What would you expect in the to see in the renal ultrasound? Based on what we said.
Normal. Nothing.
Okay. Yes.
Nothing abnormal will be there.
Yes. Okay, so it can be normal as in Miss Edwards' state, okay, normal size, or it can be slightly enlarged. We will understand why can it be in a while, okay? طيب. What other investigations are you interested in, guys?
I ran out of ideas. I don't know.
Come on, guys. You are all good, okay? Do you remember when I showed you in the previous slides about the coagulation profile and it was normal? Why do you think it's required?
For biopsy?
Excellent, Dr. Marwa. Keep it up. Okay, so let's go for the next slide. So what's next? As you suggested, it could be the renal biopsy. Okay. Okay. So أنا مش عارفة ليه ده هنا ما ظهر فيها Okay, anyway. So, okay, who can tell me about this renal biopsy? As you can see, what do you think about this kidney biopsy? Dr. Heba, can you elaborate more about it?
About the biopsy of the, we can see infiltration with the inflammatory cells or something like this.
Okay.
Destruction of the renal tubules by inflammatory tissue, a destruction of the filtering membrane or something like this.
Okay. I think this is a far away advanced question. Okay, we don't see any glomes in this one, but you are correct. We can see some renal tubules, and you can see that these small purple cells distributed in the slide can be the inflammatory cells. Okay, in the interstitium. We can see as well tubular atrophy, and if you can see my pointer, the tubules are not like quite healthy as you expect. Okay. Okay, so I am quite interested to know, what do you think about the causes of ATN, guys? What are other causes apart from the case of Miss Edwards? What do you think can cause ATN?
Antibiotics has a very important role for ATN.
Okay, that's good. What else?
It may be painkillers, special non-steroidal anti-inflammatory drugs.
Okay, that's good. What else?
Maybe omeprazole.
That's good. Okay. What else, guys?
A lot of pathogen can cause it.
Okay, good. So now we understand that's why medication history is very important. Okay. I will be reading through the next slide. So the drugs that are associated with the ATN can include antibiotics like penicillin or others like gentamicin, erythromycin, tetracyclines, NSAIDs, as we mentioned, aspirin, antacids, and diuretics as well. Okay. Somebody mentioned about infectious causes. So it can be bacterial, viral, or parasitic. Okay. Lots of bacteria and viruses can cause it. What is the pathogenesis of ATN? Dr. Hiba, can you please answer this question?
It could be regarding infectious, maybe retrograde infection from urinary tract, or one of the multi-organ affecting viral infections that interfere with the proper kidney function.
Okay, and could it be related to medications?
Yes, sure, which is more common. Medication caused renal problems due to widespread of the over-counter drug, just like non-steroidal anti-inflammatory drugs, as well as nephrotoxic antibiotics.
Okay, so I can explain this in the next slide. So some medications or pathogens can bind to the tubular interstitial components. It can alter actually the structure of these viable cells, and it can make it more immunogenic. So inflammatory cells can be attracted to it and initiate the interstitial inflammation. Okay. Okay. Do you want to know exactly like what's happened to Miss Edwards?
Sure.
Okay.
Yes.
Okay. So في حاجة ناقصة هنا المفروض تكون كانت أنا ما أعرف في سلايد ناقصة. Anyway, okay. Do you want? Okay. So now I think we should move on to treatment. Okay. How do you want to treat Miss Edwards? What do you think we should do first?
Stop any medications and maintain proper water electrolyte balance.
Okay. So you start by stopping the omeprazole, right? Because it's the
all medications. I can stop all medications.
Okay. Okay. What else?
We can add steroids.
Okay, that's good. Okay. Okay. Why do you think you want to add the steroids, Dr. Ashraf?
Because the pathogenesis may be increased immunogenicity of the tubules by some drugs, and so steroids are the most powerful anti-inflammatory and immunosuppressive drug.
Okay, so I think steroids are the magic bullets for all inflammation, as you mentioned. So we should remove the likely causative drug, which is in this case is omeprazole. We should treat hypertension and proteinuria. Usually we use ACE inhibitors or ARBs. As you mentioned, we should use steroids. Usually the dose is 1 milligram per kg for prednisolone. And if the patient had severe renal impairment with a very high, for example, potassium or urea, or she started to have fluid overload, then we should initiate renal replacement therapy. Okay. What do you think about the prognosis of Miss Edwards, guys?
A good prognosis.
Okay. Any thoughts? Other thoughts about being good?
I think it's bad.
Actually, it's good. Let's read through the next slide. So usually patients are doing good. Okay, either they gain complete or near complete recovery of the renal function once you stop the medication. But in some cases, they can have prominent damage and irreversible damage, okay? And they may not fully regain the function. And the poor prognostic factors include irreversible biopsy changes, like if they had previously any kind of fibrosis or tubular atrophy, and this is an add-on, or if they have heavy proteinuria at presentation, oliguria, persistent renal failure for more than 3 weeks, or if they had older age, okay?
Okay.
I think we can move on to the next slide. So overall outcomes for Miss Edwards. So after they stopped the omeprazole, and she was started on lisinopril 5 milligrams and prednisolone 60 milligrams, her steroids were continued for 2 weeks, and they were tapered down actually. And then she had systemic improvement within 3 days of the starting of the steroids. As I told you, it's the magic bullet for inflammation. And in the follow-up after 3 months, her blood pressure was normalized to 110/70, and her urine dipstick showed only 1 cross of protein, and creatinine is 110 micromole per liter. Okay. So I think now we are coming to the end of our presentation. Let's revise the key points and take-home messages. Can you please, Dr. Amr, read the first point?
Well, acute tubulointerstitial nephritis presents typically with fever, rash, arthralgia, loin pain, and hypertension. Investigations show acute renal failure, eosinophilia, microscopic hematuria, proteinuria, 1.5 to 2 gram per 24-hour, and eosinophilia in the urine.
Okay, Dr. Iman, can you read the next point?
A renal biopsy is useful even in cases with a classic presentation in order to confirm the diagnosis and interstitial infiltrate and edema, tubular necrosis, and assess for signs of irreversible damage, interstitial fibrosis, and tubular atrophy.
Okay, the third point, can you, Dr. Hiba, please read it?
The most common causes of acute tubular infarction necrosis are drugs and infections, although some will have no obvious cause. Idiopathic drugs associated include antibiotics, steroidal anti-inflammatory, and PPLs.
Okay, that's good. Dr. Ashraf, can you please read the fourth point?
Treatment involves stopping the causative drug or treating the causative infection, managing hypertension and proteinuria with ACE inhibitors or ARBs, and treating inflammation with oral corticosteroids, typically prednisolone 1 milligram per kilogram.
Okay, I will read the last one. Overall prognosis is good, as we mentioned, with many patients regaining normal renal function. Poor prognostic factors include older age, oliguric acute renal failure, and presence of significant interstitial fibrosis and tubular atrophy on renal biopsy. I think you did great, guys. Thank you very much for your active participation. And if you have any feedbacks or any questions, you can send me on my email or when we meet next time. Thank you very much all.
Thank you so much.